approaches are currently available to treat these more common forms of advanced non-melanoma skin cancer?
So right now, the most common mode of treatment is typically treating cancer that is localized. Again, even with the extremely increasing incidence of these cancers, the vast majority of cancers that we detect are still localized, and they can and are amenable to easy surgical eradication by a trained dermatologist or a trained Mohs surgeon. So a trained dermatologist, a trained Mohs surgeon, a plastic surgeon, these are commonly the physicians that encounter these patients, and surgical removal is still the primary mode of eradication for these lesions. However, increasingly, there is a role for early systemic therapy and local regional therapy to improve patient outcomes for reasons that we can talk about. But still, the vast majority of patients are still treated surgically. And then increasingly, there's a role for referral to medical oncologists and radiation oncologists to talk about alternative forms of treatment that may be needed after that.
And what sort of alternative therapies? Are you looking at targeted therapies, immunotherapies?
So the primary reason for which advances in advances have happened in this disease is really the advent of effective systemic immunotherapy and the spillover of immunotherapy into the patient landscape in this disease, in these diseases. And the reason for that is as follows. Immunotherapy essentially is most effective in tumors that carry a high tumor mutation burden. So for example, melanoma has a tumor mutation burden on average of about 15. And the tumor mutation burden in melanoma is driven by the fact that melanoma, cutaneous melanoma, is a skin ultraviolet light-driven skin cancer. However, non-melanoma skin cancers have tumor mutation burdens that are many, many magnitudes higher than that of melanoma. For example, the median tumor mutation burden in cutaneous squamous cell carcinoma is 50. Melanoma is 15. So the median tumor mutation burden in cutaneous squamous cell carcinoma is 3 times that of melanoma. Similarly, for Merkel cell carcinoma, a large majority of Merkel cell carcinoma is caused by an unusual virus known as the Merkel cell polyoma virus. Both the viral-driven tumors and the non-viral-driven tumors have high tumor mutation burdens. And the same is true of basal cell carcinoma because of ultraviolet light exposure. So the primary reason why immunotherapy has got a foothold in these diseases is because the underlying etiologic agent that drives carcinogenesis, ultraviolet light for the majority of these, and the Merkel cell polyoma virus for the subcategory of non-melanoma skin cancer that is Merkel, are both associated with a response to immunotherapy. And as a result of that, immunotherapy, anti-PD-1 immunotherapy, is now standard of care for patients with tumors that are either locally advanced unresectable or locally advanced and or metastatic, that is, that they have spread. And so they are now available for use, and they're FDA approved for this indication in both Merkel, basal, as well as non-melanoma cutaneous squamous cell carcinoma.